You can feel perfectly healthy, exercise regularly, have no chest pain whatsoever, while silent changes are developed inside your arteries. Because many of the conditions that increase cardiovascular risk, including abnormal cholesterol particles, insulin resistance, early kidney disease, and chronic inflammation, may produce no obvious warning signs for years. These tests do not diagnose blocked arteries by themselves, and not every person needs every test, but they can help you and your healthcare professional uncover hidden risks and decide whether lifestyle changes, treatment, or additional evaluation may be appropriate. And number one is the standard lipid panel, the familiar blood test that measures LDL cholesterol, HDL cholesterol, triglycerides, and total cholesterol. LDL carries cholesterol through your bloodstream. But when too many cholesterol-containing particles cross into a vulnerable area of the arterial walls, they can become trapped and modify it, attracting immune cells and contributing to the gradual formation of plaque. HDL is involved in transporting cholesterol away from the tissues, while elevated triglycerides may accompany insulin resistance, diabetes, obesity, fatty liver, and other metabolic problems. Here's what many people misunderstand. High LDL and triglycerides commonly cause no direct symptoms. You cannot feel cholesterol accumulating inside your arteries. Symptoms such as pressure, squeezing, burning, or heaviness in the chest, unusual shortness of breath, reduced exercise tolerance, discomfort spreading into the arm, jaw, back, or shoulders, or pain cramping in the legs while walking may indicate that cardiovascular disease has already become clinically important. And number two is apolipoprotein B, pronounced apolipoprotein B, or simply ApoB. This test can reveal information that a standard LDL cholesterol result may miss because nearly every potentially artery-damaging LDL or triglyceride-rich remnant particle carries one ApoB molecule. That means ApoB gives your healthcare professional an estimate of the total number of atherogenic particles circulating in your blood. Think of your bloodstream as a highway. LDL cholesterol tells you approximately how much cargo is being transported, while ApoB helps estimate how many vehicles are carrying that cargo. Two people may have a similar LDL cholesterol level, but one may have fewer cholesterol-rich particles, while the other has a much larger number of smaller particles. More particles can mean more opportunities for them to enter the artery wall and contribute to plaque formation. ApoB can be particularly helpful when someone has elevated triglycerides, diabetes, metabolic syndrome, abdominal weight gain, fatty liver, or an LDL result that appears acceptable despite other cardiovascular concerns. Elevated ApoB itself usually causes no noticeable symptoms, but associated clues may include increasing waist size, elevated blood pressure, high triglycerides, low LDL, darkened velvety skin around the neck or underarms from insulin resistance, or a strong family history of early cardiovascular disease. Number three is lipoprotein A, pronounced lipoprotein(a), or simply Lp(a). Lpa is an LDL-like cholesterol-carrying particle with an additional protein called apolipoprotein A attached to it. Your Lpa level is largely determined by genetics, so a person can eat well, exercise, maintain a healthy weight, and still have an elevated level. High Lpa may contribute to plaque formation, inflammation, clotting, increased risk of heart attack, stroke, peripheral artery disease, and calcific aortic valve disease. Most people with elevated Lpa have absolutely no symptoms and is not included automatically in a standard cholesterol panel. Family history, therefore, becomes extremely important. Ask whether a parent, sibling, or grandparent experiences a heart attack or stroke unusually early in life, whether someone required a stent or bypass operation at a young age. Number four is hemoglobin A1C, often evaluated along with fasting glucose when appropriate. When glucose enters your bloodstream, some of it attaches to your hemoglobin inside your red blood cells. The A1C test measures the percentage of hemoglobin carrying glucose and provides an estimate of your average blood sugar over roughly the previous 3 months. Persistently elevated glucose can damage the endothelium, the delicate inner lining of your blood vessels, while increasing oxidative stress, inflammation, and chemical modification of proteins. Over time, this can accelerate disease in the arteries, supplying the heart, the brain, kidneys, eyes, nerves, as well as your legs. Prediabetes frequently produces no symptoms, which is exactly why testing matters. As blood sugar rises further, some people may develop increased thirst, frequent urination, unusual fatigue, blurred vision, slow healing wounds, recurrent infections, numbness or tingling in the hands or feet, unexplained weight changes, or darkened skin around the neck or underarms. An A1C below 5.7 is generally considered normal. 5.7 through 6.4 falls within the prediabetes range, and 6.5% or higher may indicate diabetes when properly confirmed and interpreted. And number 5 is kidney evaluation, including blood creatinine, an estimated glomerular filtration rate called eGFR, along with a urine albumin-to-creatinine ratio when appropriate. Although the urine albumin test is not a blood test, it belongs in the discussion because kidney filtration and leakage provides different and complementary information. Creatinine is a waste product used to estimate how effectively the kidneys filter the blood, while urine albumin can reveal injury to the tiny blood vessels of the kidneys even when the eGFR is still relatively preserved. The heart, arteries, and kidneys are not separate systems. They constantly influence one another. And a useful bonus test for selected people is high-sensitivity C-reactive protein, or what we call hsCRP. This blood test measures a marker of inflammation that may add information when cardiovascular risk is uncertain. Even in someone whose cholesterol appears relatively normal, but their CRP is not specific to the heart, and an elevated result does not prove that the coronary arteries are inflamed or blocked. Infection, injury, arthritis, obesity, dental disease, and many other conditions can raise it. So an abnormal result may need to be repeated when the person is otherwise well and interpreted along the rest of the clinical picture. Now here is the message I want you to remember. These laboratory tests are pieces of a much larger cardiovascular puzzle. No single number can predict with certainty whether you will have a heart attack, and a normal result does not automatically guarantee that your arteries are clear. Your healthcare professional should combine these findings with your age, blood pressure, family history, smoking status, activity level, nutrition, sleep, waist size, medications, diabetes status, kidney health, and sometimes imaging such as a coronary artery calcium scan. And ask your doctor to understand your LDL, HDL, and triglycerides. Ask whether your ApoB could reveal an elevated number of any harmful particles. Ask whether you have ever had an LPA measured. Ask and know your A1C and glucose. Understand your creatinine, your GFR, your urine albumin, and discuss whether your CRP or coronary calcium imaging would add meaningful information in your individual situation. Most importantly, never wait for routine laboratory testing. When you develop new chest pressure, severe or unexplained shortness of breath, fainting, cold sweating, sudden weakness or numbness, facial drooping, difficulty speaking, or pain spreading into your arm, jaw, shoulder, back, those warning signs require immediate emergency evaluation. The goal of these tests is not to frighten you. It's to discover the risk while there is still time to protect your arteries, support your metabolism, preserve your kidneys, and make informed decisions that may protect your heart and brain for years to come. I only wish you, your loved ones, good health. Please leave your comments below, and most important, make it a great day. I'm Dr.